everybody. Welcome to another episode of 10 Rules. I'm your host, Yaron Ivan, as usual. And we have another episode today with my previous scribe, now an exceptional medical student and a podcast researcher, Victoria, who's going to help us address a very important topic today, the topic of fever in children. All right. Thank you, Victoria, for coming on the show again. Last time, I'm sure everybody remembers, we discussed some important topic regarding anaphylaxis, about the treatments, the management, and we kind of concluded most of the stuff that we already know. We already knew that with the management of anaphylaxis, EpiPen is a must. Some proof and some evidence for the adjunct therapies, namely steroids, albuterol, and whatnot, but by all means, not as necessary. This time, Victoria, we're looking into a totally different topic. Thanks again for coming on the show. What are we talking about today?
Hi, Yaron. Thank you so much for having me today.
Hello.
I'm so excited to be talking about this topic on the podcast today because I know it's something that we've always talked about looking into or investigating. And while it's an extremely vast, complicated, and somewhat controversial topic, hopefully our discussion today can help to simplify things a little bit. So this time around, our research questions were the following. Is fever in pediatric patients harmful or dangerous? Is it necessary to suppress fever? Or on the other hand, is it harmful for us to suppress fever? AKA, will it prolong the duration of the illness? And finally, is it dangerous to leave fevers untreated? Is there any actual risk of inducing febrile seizures?
All right. So tell me, Victoria, what did you find? This is a great topic, by the way. Fever keeps us pediatric emergency medicine doctors employed. It's a huge topic. It's a very common chief complaint. It freaks parents out. Parents really worry about fever. I got to be honest, I have 3 kids. When my kids have fever, I also worry. So what did you find?
Okay, so based on my research of the literature, and again, a lot of this is talking about benign fevers, so not fevers that are due to other more serious conditions going on, but the vast majority of the articles that were written in a clinical context were able to agree on a few statements as follow, and that is that fever is a physiological response mechanism by the body to fight infection, and more oftentimes than not, it should be allowed to do so. Fever in itself is not dangerous and has not been shown to lead to or increase the risk of febrile seizures, which again are benign themselves and do not cause brain damage. Yaron, I always remember you teaching us that if a child is going to get a febrile seizure, it's not really about the number or how high the fever is. What has your experience been with this in your practice?
Yes, so that's a good question. I was always taught exactly that. And the way I phrase it to parents is febrile children who get Tylenol around the clock still get febrile seizures. We used to think it's because of the fever, meaning the fever is the direct cause of the seizures. And now we no longer think it's true. So suppressing the fever does not prevent the next febrile seizure. So that's what I always learned. That's why I tell parents.
Awesome. And yeah, a lot of what I found pretty much goes along with that. Another point was that antipyretics cannot prevent the occurrence of febrile seizures. So like you just said, and all of that being said, the overall consensus is that there's currently not enough recent evidence or investigation into whether or not treating or suppressing a fever actually has an effect on outcomes or prolongs the illness. This is really because the majority of the data we have on this is historical data from research that was done very early in the years of research into the topic. And it was like in the 1960s, it dates back to that, where they were looking at drugs like aspirin and things that are not given to children with viral illnesses anymore, as we've learned because of hepatic encephalopathy and all of that. But basically, years ago, there were some experiments that showed that viral shedding was prolonged whenever a fever was treated. But all of that is outdated at this point, and we just don't have enough new experiments on the topic.
All right. So that to me, I think, is very interesting because I think we all know that fever is just part of the immune system, and to me, if you take the immune system and you suppress an aspect of it, you're probably not doing a whole lot of good to the patient, potentially increasing the duration of the illness and making things potentially worse or just longer. So I'll be very interested to see what the historical data that you found and if there are any new data. So tell me, Victoria, were there any specific articles that you came about that we want to talk about?
Yeah, so one of the first articles I looked into, it was called "Is a Fever Harmful or Beneficial, and When Should It Be Treated?" It was published by the American Academy of Pediatrics on May 3rd, 2019, by Dr. Meissner. And he basically makes the following statements. Most of the available studies have failed to demonstrate that the use of an antipyretic will prevent febrile seizures. No current significant clinical evidence suggests that antipyretic use delays the resolution of bacterial or viral infections. And thus, a reasonable conclusion is that use of antipyretic medication to reduce fever and its complications is not harmful per se and does not slow the resolution of common viral and bacterial infections in children. To me, this seems like something that's a little bit tricky to prove clinically, because how can we really know if it's, again, prolonging the illness or slowing resolution? But I think his comments can be interpreted more as like, a child who's in significant discomfort due to the fever, if they're in pain, if they're excessively lethargic, if they're uncomfortable, it may be worth it to treat the fever, as the child will likely feel more comfortable and be more willing to take fluids. But this does not support treating every high temperature that you see. Like a lot of the doctors that I've worked with always say to me, we treat the patient, not the number.
And I completely agree with that. One of the things I tell parents is treat the fever when the fever bothers the child, not when it bothers you. I see a lot of kids with 103 in the ER with a positive popsicle sign, watching TV, happy, smiling. In my opinion, those kids should be left alone because it doesn't bother them. But certainly, and I agree, if the fever makes the kid achy and cranky and the kid is not drinking, that can lead to dehydration. Certainly reasonable to treat. If the child is not sleeping through the night, and I would consider sleep a very important part of healing, certainly reasonable to treat, but treat the patient when the patient is bothered by the fever, not when it bothers the parent, sorry. Did you find, Victoria, any articles that support the opposite, in other ways that antipyretics do lead to slower resolution of symptoms?
So yeah, in an effort to look at both sides of the argument, I did come across an article called "Fever Management Evidence versus Current Practice Guidelines" that was published December 8th of 2012. And basically, the author, Sahib El-Radi, they give a pretty extensive argument about allowing the benefit of allowing a fever to run its course. And they talk about the molecular biology of how a fever works and what that means for suppressing it. But again, this is not enough clinical evidence really to show that suppressing a fever in practice will delay resolution. So the author talks a little bit about how, and this is a lot of the stuff that we learn in medical school traditionally, about how fever exerts an overall negative effect on the growth of bacteria and replication of viruses. It also enhances our immune response because many of components of our immune response, like interleukin-1 and T helper cells, B cells, immunoglobulins, they all function better at elevated temperatures. So, for example, if you're looking at polymorphonuclear leukocytes, PMNs, their mobility, phagocytosis, and killing of bacteria all are significantly greater at temperatures above 40 degrees Celsius. No experiments or studies have really looked into children with temperature above 40 degrees Celsius, but elevated temperatures at around 38 to 39 degrees Celsius have a directly positive effect on lymphocytes and overall all of our immune processes. And so, for example, IL-1 is more active at febrile temperatures than at afebrile temperatures. And interferon, which we know is a potent antiviral agent, has also enhanced antiviral activity above 40 degrees Celsius. So you can definitely make the argument that all of these immune processes that we get when we have a febrile illness function better because of the fever. But again, that's not to say that this has any relevant clinical effect. And so this author also found that a sudden fever may cause a harmless febrile seizure or convulsion in 3 to 5% of those who are susceptible. So I think the key here is that some people are just genetically more susceptible to developing febrile seizures, but there is no evidence to say that the fever is the cause of that or the fever somehow induced the seizure. Like with most things, some people are just more susceptible. And so if they're going to develop a febrile seizure, giving antipyretics prophylactically does not prevent that from occurring. And again, this author stated that seizure does not cause brain damage, which we know from excessive evidence. Of note is that there's some situations that are exempt. Like I mentioned at the beginning of this, we're mostly just talking about benign fevers in harmless conditions. We're not talking about conditions in which there's an increased metabolic rate, such as burns or cardiovascular pulmonary diseases. In those scenarios, letting a fever run its course could actually be dangerous because it's going to lead to increased oxygen requirements, increase the metabolic rate even more, and just increase all of the demands from the child. And that would actually worsen the disease. So we're mostly just talking about benign viral and illnesses that don't really have any direct impact on respiratory and cardiovascular function. What I thought was nice and that this author sort of concludes the argument is that they sort of call to action, stating that we do need more research and more investigation looking into what kinds of infectious or diseases benefit from suppression of fever versus allowing the fever to run its course, because we can't really lump everything into one category and treat it the same way. Some things may benefit from treating a fever and other things may benefit from allowing to run its course. So I think that's something that should be looked into in the future.
Yeah, so those are all really good points. We need research to prove statements like that and courses of treatments. Every disease is different until proven otherwise. So maybe for some viruses, suppressing the fever may prolong the illness and viral shedding and whatnot. And for other viruses or some other diseases or conditions, it will not. And I think that's also a very important point that you make. And I tell that again to parents all the time. There's difference between a healthy child with a viral illness or a child in sepsis with increased metabolic demand, whose fever is just making things worse and increased oxygen requirement, etc. In those situations, there's almost definitely some benefit of suppressing the fever because the body is already going through so much. But a healthy, normal baby or child with viral illness, I think that's a whole different ballgame. So those are all very, very good points. Victoria, what else did you find?
Yeah, so I found an article by authors Dr. David Aronoff and Dr. Eric Nielsen, and basically they again looked at the cell biology and the molecular impact of fever, and they attempted to relate it to clinical practice. And this was actually the article that talked about some of the older experiments that we had and where a lot of the practice of treating fevers came from, because this was all we had for a while. But the authors basically made some of the following conclusions, and that's that it still remains unclear whether reducing the core temperature benefits febrile patients, because like you mentioned, elevation of the core temperature during the fever is a controlled process that our body carries out. And so it still remains a little bit unclear whether by bringing that down with medications, if it benefits or hurts the patient. A recent controlled trial done that they talked about in this article looked at the use of ibuprofen to prevent recurrent febrile seizures, and that failed to show any significant benefit to giving the ibuprofen. And the same thing was done with acetaminophen, which again, both did not show any benefit in prophylactically giving these medications to prevent febrile seizures. And the authors also make a really good point in talking about the fact that a lot of febrile patients, children, are not uncomfortable simply because of the elevated temperature. Most of the discomfort comes from the inflammatory response that's going on when someone is sick. And so another way to sort of look at that or get around it would be to use non-antipyretic medications to sort of make the child more comfortable, but not necessarily bring the fever down. Again, the authors just reiterate that much of the available data we have right now don't give any sort of contraindication to treating high temperatures. And that's sort of the reason why it comes down to individualizing the decision for your patient and sort of deciding, is treating this child going to make their symptoms better? Is it going to make them recover faster? Which are all important things to keep in mind. Like I talked a little bit about before, the notion that antipyretics depress the immune response to bacterial infections dates back to the 1960s, where they did some experiments and noticed that activation of latent infection had been reported in patients who took NSAIDs. And they saw sort of a similar thing with giving patients aspirin who had viral illnesses, and the patients would actually shed the viruses for longer times after receiving aspirin. And some studies that were done back in the day, looking at parasitic diseases, also indicated that acetaminophen use lengthened the host response to malaria in children. And so, like I mentioned before, one approach to treating febrile illnesses is to use alternative non-antipyretic medications just for analgesia and for symptom relief. And so basically that all goes to say that we don't have any concrete evidence that treating the fever will prolong the illness. All we have is the molecular explanations of why the fever is going on. And so I think that says a lot about making a clinical decision and only bringing down the temperature when you have clinical reasons to bring that temperature down.
Yeah, so those are very important points, Victoria, because oftentimes science makes some findings in the labs, and extrapolating them to clinical practice doesn't always work. So yeah, it certainly seems, and we certainly know, that fever is part of the immune response. One would think that if you suppress it, you suppress the immune response, but that may or may not be true. So extrapolating that to clinical medicine takes a lot of research and some evidence. You can't just say that. But those are very good points. Tell me, in terms of more clinically centered approach to the topic, what else did you find? What other articles?
So I found a really good article by Dr. Tessa Davis, who's in the Department of Pediatric Emergency at Sydney Children's Hospital in Australia. And this goes really nicely with your podcast and sort of the theme here. And that's just sort of looking at, the article was looking at the most recent National Institute for Health and Care Excellence guidelines, or the NICE guidelines, for treatment of fever in children less than 5 years old. And she talks about the traffic light system and basically outlines some of the most important anticipatory guidelines to give parents. So this has a very important clinical implications, because these are the type of things that we want to be telling the parents and teaching them in order to avoid this pressure to bring temperatures down when it may not really be necessary. And so some of the things that she mentions is that clinicians should try to explain to parents that once a child is over 6 months of age, the height of the temperature does not necessarily mean that the child is more sick. Yaron, I know you already talked about this in your last episode on the podcast, the newborn talk to young parents, and how after 6 months, most children will hopefully be fully vaccinated against any serious harmful bugs. Do you have any other thoughts or explanations for this point?
I don't think so. I think indirectly what that doctor means is that, yes, simply put, fever after 6 months of age, when you got your pneumococcus vaccine and your H-flu vaccine, is almost always viral. Add to that, from a clinical standpoint, when I see a child younger than that age or that age with fever, we do know that, unfortunately, I know smart people are working on it, but we have no vaccine for E. coli or UTI. So that is an SBI, a serious bacterial illness that is still out there. So I always encourage my students and my residents to get a UA on a febrile newborn, 2, 4, 6 months of age, even if they're fully vaccinated, because unfortunately that doesn't count. We do know that UTI prevalence goes down with age, but one of my pet peeves is that you can never go wrong getting a UA on a febrile newborn. But I think she basically means that after 6 months of age, just fever is so unlikely to represent any serious infections.
Yeah, that's a very good point. And I do remember you always teaching that, because I still remember to this day. Another one of the advice that she had was to advise parents to only give acetaminophen or ibuprofen if the child seems distressed and not just because of the temperature, which again goes along with everything we've been saying thus far. Another point is that parents should be advised to give only one antipyretic at a time and not both together. I think this is likely due to the fact that giving both is a little bit redundant and the risk-benefit analysis of giving both is not favorable. And like you mentioned before, it can lead to overdosing and confusion. So I think that's why you sort of tell the parents to stick to one at a time and just alternate. Do you have anything to comment on that?
Yeah, so I agree with you. I think that's something that I hear from parents because they were told that by other providers that they can alternate the Tylenol and the Motrin. And I think it's a lot of math. It's a potential for disaster. It's a very slippery slope. I don't think I've ever seen a child that age that was overdosed, clinically overdosed on Tylenol. So I think it's going to be very hard to cause harmful effects from Tylenol or Motrin by treating a kid for 2 or 3 days. But certainly it's something we worry about. And again, I'm not sure it's necessary. Generally speaking, if you stick to one medication, the child does fairly well. So I'm all about less is more, as you know.
Okay, great. Some of the other pieces of advice that she talked about was to advise parents not to overwrap or underdress a child with a fever, and that tepid sponging is not recommended. Overall, you want to explain that lowering the temperature does not, in fact, prevent febrile convulsion, and that antipyretics should not be given just for that purpose. And as always, with any emergency department visit, you want to extensively educate the parents on how to recognize amber or red signs. Are there any red signs that you think are important to include in this discussion?
I think from my standpoint in the Pediatric Emergency Department, because we see a lot of kids with fever, we therefore see a lot of kids with tachycardia. And one of the things that I'm very strict on with the residents and the students is if the child is febrile and tachycardic, assuming he's vaccinated, assuming he's not ill appearing, I don't worry particularly much. I think, again, we know that most kids are febrile for benign viral illness. And if the tachycardia is proportional, I'm okay with that. I'm always a little weary about the child who's not febrile and is very tachycardic. To me, that is sepsis and the fever is just hidden because mom is giving Tylenol, or maybe the child is dehydrated, or maybe there's something else that I'm missing. So unexplained tachycardia for me as a provider is much more scary than a child with fever and tachycardia that is proportional and is vaccinated and is not ill appearing.
What a great clinical pearl. The final article that I looked at was actually a study done by E. Chapney. It was published January 2017, and it was titled The 2016 Update of the Italian Pediatric Society Guidelines for Management of Fever in Children. And this study was basically done to look for the scientific evidence in order to update guidelines for treating children with fever. And the study found no statistically significant difference in the rate of febrile seizures between children who received prophylactic antipyretics and those who received placebo. And so, taking all of that into consideration, they concluded that antipyretics should be administered only with the purpose to control the child's discomfort and are not recommended preemptively to reduce the incidence of fever or prevent febrile seizures or prevent seizures in patients getting vaccinations. I think this is likely because we've already seen a great deal of evidence to support that prophylactic antipyretics will not prevent febrile seizures. And any fever or febrile seizure that a patient gets after vaccination is usually benign and self-limited.
Very good. So that I agree with completely. I'm actually giving a talk about fever and effects of fever next month on the ACOEP Clinical Assembly, which you will be a part of when you graduate and become an attending. And I'm actually aware of 1 or 2 studies that actually gave low-dose benzodiazepines for febrile kids with history of febrile seizures. And even the benzodiazepines, which are considered gold standard anti-epileptic or anti-seizure medications, did not prevent febrile seizures. So those kids with febrile seizures continue to have intermittent febrile seizures despite treatment, scheduled treatment with benzodiazepine, which I think is just really amazing to think that even the gold standard anti-epileptic or anti-seizure medication for some reason does not help with febrile seizures. Helps with epilepsy most of the time, but it doesn't help with febrile seizures. So clearly there's something about febrile seizures that we still don't understand or don't know.
Yeah, and that really says a lot about how it's not really worth it to give antipyretics. And hopefully there'll be more research that's probably in the works now or in the future about a possible treatment for febrile seizures, because I know that has to be something that's really scary for parents.
So this is your opportunity to shine, Victoria, and do that research when you finish med school.
So just to conclude our discussion today, I just wanted to say that although there still remains some degree of controversy about the cellular and molecular implications of fever and if it's beneficial or harmful, we currently have a pretty good amount of research and data to support a more conservative approach to treatment of benign asymptomatic fevers in pediatric patients. And so we should make an effort to decrease the current prevalence of routinely treating high temperatures, as there is no evidence that this approach is beneficial to the child. And sort of on the other side, it sends a message to caregivers that fever is harmful and that treating fevers is beneficial, which is just simply not supported by current scientific evidence. So, as with most things in medicine, evidence-based education and anticipatory guidance are the best ways to eliminate fear, misconceptions, and reduce unnecessary use of health services.
Yes, and I could not agree more. I think I call it setting up the expectations. Giving Tylenol around the clock doesn't really do a whole lot. If the child is happy with the fever, be happy with the fever. If he's unhappy with low-grade temperature, treat him, make him comfortable. So those are really, really good findings. Excellent job, Victoria, as usual, as a scribe, as a medical student, as a podcast researcher. Thank you very much. I know you're a busy student, so I appreciate you doing all this work and coming on the show. I guess we'll have to find another topic.
Thank you for having me. As always, it's such a joy and so much fun to make an episode, and I love this podcast, so it truly is an honor.
Appreciate it very much, Victoria. We'll see you next time. Thank you again for listening, guys. I appreciate it. I hope you enjoyed the show. I hope you tune in next time. I hope you like Guns N' Roses. This is one of my favorite songs by them. Took a while to learn this one. I'm no slash in any way.